Okay, I'd like to welcome everyone to the MD Anderson Cancer Center Integrative Diagnostic Medicine Case Conference for May 22nd, 2020. Thank you for attending. Much appreciated. This is a special edition. I think it's actually going to become a permanent edition because of the COVID-19. I think this is the new normal, so I'm probably going to stop the special edition soon. So this is Lunch and Learn Happy Hour Bedtime Stories, depending on where you are in the world. Okay, let's get started. It's customary. I always like to start with a warm-up. You can't just jump into the cases. So let's do histology warm-up. All right, everybody ready? Histology warm-up. So what I want to know is, what does the histology show? What are you seeing in the glass slide? Okay, you remember you can use the chat function to text and I will see your answers. Now, if you're thinking that I messed up, that this should have been imaging warm-up, it's not imaging warm-up, it's histology warm-up. So it doesn't matter if you're a radiologist or a pathologist, when you see this image, and this is an axial T2 flare sequence, coronal T2 flare sequence, you should be seeing histology. In your mind, you should be seeing what that H&E shows, what it's going to show at frozen section. You should be seeing diffuse glioma. You should be seeing the diffuse glioma infiltrating the white matter up into the cortical ribbon. You should be seeing secondary Shearer structures, perineural satellotosis, perivascular satellotosis, subpeel growth. All of that is visible on this image to the trained eye. That is the point. However, I will show you histology. Here's a frozen section. We need to do more smears, intraoperative cytologic prep smears, touches, squashes, drags, and frozen sections. And I'm going to try to incorporate frozen sections more as we go along the course. Okay, here's a frozen section. As you can see, neuropil in the background. I think here's a second frozen section. Okay, what's your diagnosis or differential diagnosis? Anyone want to chat? Anyone want to play? Yeah, maybe I'm just not seeing the answers. I know it takes time to type. It's very irritating. And that's one of the disadvantages of WebEx is I can't hear people talking, even the ones that whisper very softly, and it's irritating to have to type, but that's okay. Yes, okay, Dr. Harb actually got it correct. I'm not going to tell what the correct diagnosis is. I'm going to take just a second here. You should be thinking diffuse glioma, and the best frozen section diagnosis would be diffuse glioma, typing and molecular classification deferred to permanent. Okay, all right, let's go to, this is the FFPE, formalin fixed paraffin embedded. Everyone want to stick with your diagnosis? And the question is really diffuse astrocytoma or oligodendroglioma. I mean, that's a differential for the diffuse glioma. There's really only the two categories, and then we stratify them molecularly, et cetera. Okay, here's the FFPE of the non-frozen tissue. Classic oligodendroglioma. Yeah, beautiful perinuclear halos. It's an artifact, this cleared cytoplasm of formalin fixation. Now let's see, if we go back for a second, I also call this FFPE, formalin fixed paraffin embedded, and it is formalin fixed paraffin embedded. It's the formalin fixed paraffin embedded slide of the frozen section tissue, which is done at most institutions. They process the frozen block into paraffin, and then they compare it with the frozen section slide for quality assurance, et cetera. Here's the point. Once the tissue has been frozen, the artifacts induced by the freezing process, which is to distort everything, especially round regular nuclei, or distorted to look like astrocytoma, that artifact is maintained when it's processed into paraffin. So the paraffin has no magic power. It's the freezing which distorts the nuclei, right? And it is very common if you're a neophyte, if you're green, you get a case in from the outside, you pick up what looks like a nice FFPE section, you see all these irregular nuclei, maybe you don't see the ice crystal artifact because it's a really good frozen, prepared by a really good frozen section lab in Histotech, and you don't appreciate that it's frozen, you could go down the tubes. So you have to be careful, all right? So this is frozen section number one. The point is, this is the single most common cause of frozen section final diagnosis discrepancy in oncologic neuropathology in the community. And that is calling molecular oligodendroglioma is the final diagnosis, diffuse astrocytoma on the frozen, because there are no perinuclear halos and the nuclei are started by the breeding process to make them look like astrocytoma. Okay, so that was just a quick little lesson for anyone who may have fallen into that trap. Hopefully you will not fall into that trap in the future. And again, always keep in mind that just because it was cut from a paraffin block, if the tissue was frozen before, it can have this artifact. Okay, that was fun. I really enjoyed that. Then here's the beautiful FFPE. Okay, and this was the case. Anaplastic oligodendroglioma, IDH mutant, and 1p19q co-deleted, WHO grade 3. And again, we're using the Arabic numerals now for designation, not Roman numerals. You can see it has a classic molecular signature. It was positive for the mutant protein IDH1R132H and 1p19q whole arm co-deletion positive, retained expression of ATRX, negative for p53, meaning no TP53 mutation. Okay, that was good. So that was the histology warm-up. Let's do a CT challenge. All right, move to imaging. Ready for CT challenge? What I want to know is what's at the top of your differential diagnosis. Normally, I would just say, what is your diagnosis? I hesitate to do that a little bit because there may be some people attending the conference that haven't attended in the past. And I'm not saying that any given image, any given molecular signature is pathognomonic. It's always a differential. What I'm asking for is based on the features that you see, the data that you have, what is at the top of your list? Okay, everybody ready to play? Here we go. What's your diagnosis? Or what's at the top of your differential diagnosis? And I'll give you, yeah, Dr. Cathcart is correct. Dr. Harb is correct. All right. Okay, that's good. That's perfect. What we're actually seeing here is curvilinear calcification, and it's actually trying to make in bits and pieces a circle. It looks like around the tumor. This is the surgical specimen. Yeah, gyriform calcification, Dr. Harb, exactly. All right, here's the what type of surgical specimen are we looking at? You notice all the blood, you got chunks of tissue, and you have all of the bubbles. Yes, Dr. Gilbert, Andrew Gilbert, neuropathologist, San Antonio. Dr. Alfatal, CUSA, absolutely. This is cavitational ultrasonic surgical aspiration, all right? It could have been taken by a CUSA instrument, all right? Cavitron, that's a trademark. It could have been taken by Sonopet. Sonopet is a competing company. So the abbreviation CUSA is trademarked, but cavitational ultrasonic surgical aspiration, the process is certainly not trademarked. So this is a CUSA specimen. We have to be very careful of artifacts, etc. And again, another oligodendroglioma, a classic round, regular, monotonous nuclei, cytoplasmic clearing. So in this particular case, that calcification was predictive of oligodendroglioma. It doesn't have to be curvilinear, or if the microcalcifications in the cortical ribbon coalesce, it can actually be gyriform, actually following the paths of the gyruses when it's severe, or it can simply be chunky calcification. Astrocytomas, diffuse astros, absolutely can calcify. It's not pathognomonic, but it is highly suggestive. It says put oligo at the top of your differential diagnosis. Okay, and this was the case I just showed you. I always like to give other examples so you don't fix one thing in your mind. So here are 4 different patients, and you can see CT scan images on the top, and either a T2 gradient or susceptibility on the bottom. Both beautifully show this curvilinear, and for the last 2 patients, 3 and 4, actually gyriform, because it's outlining an entire gyrus, at least a couple of them there. Well, this is the spectrum of calcification. So even patient number 1 on the far left, that is still very helpful to see that curvilinear calcification, and it's going to put oligo number 1. Now, again, caveat, many oligos do not calcify at all. So the absence of calcification certainly does not exclude a diagnosis of oligodendroglioma, but the positive predictive value is quite high. It's not 100%, but it's high. Okay, this is a feature that I introduced into our event. I think it was last week, or not last week. We didn't meet last week. Real life neurohistology. All right. So, question: what neuroanatomic structure are we seeing here in this real life? This is what you're going to see if you are a physician, a surgical pathologist. You're not going to see the stuff that Leo Ballister and I put in histology for pathologists. Okay, I've got one vote, Dr. Gilbert, for leptomeninges. That's focusing on the blood vessels. I agree, there absolutely are blood vessels here. No question about it. Why is this difficult? Why am I calling it real life? Because the whole thing is cauterized. What you're seeing is marked cautery artifact. But cautery artifact is like any other artifact, like H&E. It's interpretable to the trained eye. There are two easily identifiable keys on the slide if you take your time to look carefully. And it has nothing to do with the blood vessels, not the blood vessels. What else do you see? You see two structures, which when you put them together, you can figure out this is normal neuroanatomy we're talking about. It's not a tumor, normal neuroanatomy. Okay? Yeah, all right. Question, this is the same case, we're gonna get there. What is the structure identified by the yellow arrows? This is the pre-op imaging of the tissue that I just showed you, and you can see clearly there's a mass there. What's the structure identified by the yellow arrows? Anyone put that together? I know the neuroradiologist. Yeah, Dr. Gilbert, UT San Antonio neuropathologist, spinal cord, absolutely. Little bit of compression going on, absolutely. So the mass is severely, this might even be a Simpson 3 compression, and it's extending out into the soft tissue. This is kind of a messy one, but what do we typically call that shape? When a tumor extends from within the vertebral canal, typically intradural, extramedullary, or extradural in the spinal canal, vertebral canal, extramedullary mass compressing the cord that extends out through a vertebral foramen. What do we call that? That's usually called, well, dumbbell. Call it a dumbbell tumor. Yeah, that is correct. Dr. Gilbert is right again. And what is the most common diagnosis for dumbbell tumor of the spinal cord? What's the most common diagnosis? The most likely diagnosis? And we're talking bread and butter. Yes, Dr. Gilbert again, schwannoma. Dr. Gilbert is in Dr. Cathcart right behind her. You know, this is actually not fair because we're testing speed of typing. I type with one finger of one hand. Okay, I do that by choice. So I am going to be penalized at any game that requires fast typing. So thank you for playing. Yes, this is a schwannoma. It's a big schwannoma. All right. Do you think it's a malignant peripheral nerve sheath tumor? Does it look bad? All right. Do you know what the key was to this? The key to this, this was Dr. Larry Rines, our chief of spine surgery in the neurosurgery department. Dr. Rines said, I knew this was going to be a grade 1 schwannoma. How? I asked. He said, because the patient for signs and symptoms is essentially asymptomatic. A tumor doesn't get this big with an asymptomatic patient, and that it is slow over time, years and years. That's why we all have to be physicians, not just readers of patterns. Isn't that beautiful? Okay, so it's a spinal cord, it's a C6 level. What's your diagnosis? Oh, there's a nice, you can see on the left, a nice sagittal section. You can see extension. There's a very large schwannoma, one of the biggest I've seen in a while. Again, these are all current cases within the last two or three weeks. Schwannoma up to a grade 1. Okay, I will repeat my question then. Let's go back to the surgical specimen. Now, yes, the surgical specimen included the schwannoma. I'm not going to show you a schwannoma. Why would I do that? Actually, Dr. Ginsburg brought this up. Okay, yes, Esther Bitt-Ivins. Yes, this is a dorsal root ganglion. All right, good job. Look, the key features, let's see if I can do this. Right here, you can see the arrow. That is a ganglion cell with a ganglion cell with satellite cells. And right here, here's another ganglion cell. Look at this one up here. You don't see the nucleus, but you can see the ring of satellite cells. And what's that brown pigment? That is lipofuscin, and lipofuscin is present in dorsal root ganglion cells. So this is a C6 dorsal root ganglion. Now, what was the other feature? One of the features was, let's count them. 1, 2, 3, 4, 5, see them down here, 6. Okay, come on, 6 ganglion cells and you couldn't get this? I'm being mean. All right, look at this. Look, what are these things? Look over here. See just to the right and lower right of the legend. What are all those spaces with the distorted circles? They should be perfectly round. They're a little bit oval. Those are myelinated axons. And the ring, just like sort of like with the oligodendrocytes, the ring is the extracted myelin sheath, right? And the center is the axon. So you're seeing these axons in cross section. Like, come on, axons and ganglion cells, and you know it's a schwannoma, dorsal root ganglion. Okay, was that fun? Did you enjoy that? Look, this is a real life experience for the surgical pathologist. You're going to have to be able to deal with less than ideal circumstances. And it's possible, depending on the context, that being able to recognize ganglion cells, even distorted ganglion cells, can save you. And knowing that this is peripheral nerve, you see peripheral nerve for anatomic compartment, etc. And I'm really sorry that it doesn't look like the beautiful photo that Dr. Ballister and I put in Histology Pathologist, but you know, that book, I'm not going to criticize it. I enjoy it, but this is what we need to make a book of normal histology, this stuff. You like it? Okay, yellow arrows, black arrows. The yellow areas are the ganglion cells, the black arrows are myelinated axons. How do I know they're myelinated axons, but besides the fact that they're surrounded by a clear area, which I know is extracted myelin sheaths? Well, I know they're myelinated. I know they're not unmyelinated axons. How do I know that? This is a favorite question of Dr. Langford, Dr. Lauren Langford, professor of pathology, neuropathologist at the Cancer Center, to ask. You cannot see unmyelinated axons but with the naked eye. That requires thin sections, all right, EPON embedded in electron microscopy. Very good. Ganglion cells and myelinated axons. All right, that was, and cautery artifact is what made this case so much fun. Okay, and maybe that's the best attitude rather than saying, oh no, here's another crushed, distorted specimen. How about view it as a challenge? How much information can you extract from it? Okay, that's a good attitude. Okay, don't be lazy. Now, don't be lazy is actually, doesn't relate to the case we just saw. Don't be lazy relates, this is actually a new conference feature. I'm gonna call it Don't Be Lazy. All right, don't be lazy, case number 1. All right, this is outside institution report. And here it is from their report. Final diagnosis: brain, left frontal mass. It was biopsy, glioblastoma multiforme, Dubcho grade 4. Okay, very good. Arabic numeral. I like that. So we know that it was left frontal lobe, and you know, every surgical pathology fellow, every surgical pathology resident listening to this talk all the world, when you get in these outside cases, you pretty much put down, you know, where did that left frontal mass, where did that come from? Did the pathologist make that up? No, that came with the specimen. So the specimen comes from the operating room with a sheet that comes with the specimen, and it designates the site, or what the surgeon is calling it. And this is called left frontal mass, and that can be very helpful because anatomic location is very key. All right, this is the whole slide image of the stereotactic biopsy. And here's just one of those pieces of tissue, pseudopalisading, necrosis, if you will, glioblastoma. Yeah, and you know what the pre-op imaging showed? Irregular ring enhancing central necrosis. Yeah, glioblastoma, done and done. Question: why am I showing you this case? You had a left frontal lobe glioblastoma. What is unusual about that? Why would it warrant being shown in the IDMCC? You know, why? It wouldn't. So there's a problem. And here was the problem. There were 4 fragments. Amidst the fragments of glioblastoma, there were 4 fragments that looked like this. And this is the first fragment I saw, and I thought, wait, there's a disconnect. Something is wrong. What is wrong? Yes, Dr. Harb, it's basal ganglia. It's not left frontal lobe. It's not left frontal lobe. It's left frontal lobe basal ganglia. How do you know? Wilson's pencils. All right, again, let me show you just on the slow power. Here, there are 2. Here's one right here. All right, these are small bands of myelinated axons. Most of the round cells you're seeing there are oligodendrocytes. Here, let's go to a little bit higher power. And again, look, right here in the center, this whole band in the middle from here to here, that is one of Wilson's pencils. Myelinated fiber bundles. Look, on both sides, surrounding on both sides, it's gray matter. Recognize the neuropil. There are neurons. These are neurons. There are neurons over here, as well as astrocytes. 99% of the cells that you are seeing here in the bundle are regular, round. These are oligodendrocytes. This is telling, oh, and there's a few creepy crawly tumor cells as well. Looks like we've got about 3 of the glioblastoma cells that are on the highway. They hopped on the bus. All right, and so the pencil bundles here are the bus that they're going to use to get out of town, all right, to better territory. All right, yeah, all right, so bottom line is the tissue is telling us this. This is another fragment. Spot the Wilson's pencil right here in the center. That's a little more subtle, right? How about this? There's actually 2. Look in the upper left. Can you pick it up now? How it's different from the surrounding neuropil? And then look over here at the right. This one is really subtle, and there's some edema separation out here, but that is a Wilson's pencil. All right, it would light up with a Luxol fast blue stain. All right, here's another one. See this guy right here? That is a Wilson pencil, completely surrounded by gray matter. You don't find that essentially any place except for the basal ganglia, right? The striatum, lenticular nucleus, lobus pallidus, etc. Okay, here is the point. The histology told the pathologist the anatomic location. It did not come from the operating room. You know, that's the thing. The sheet comes to the operating room. A lot of times, that's like we used to call them idiot lights in a car. In the old days, there weren't gauges. I mean, this is way back. You know, you didn't have gauges that showed the temperature and all this stuff. What you got was a light that would come on right after the car died. This red light that basically said, you know, engine shut down or overheat. It was too late. All right, that's what that sheet is. It is up to you to be able to read the messages that the tissue is sending you. The tissue told us that this was from the basal ganglia. Do you like that? All right, you think I'm making it up? Well, here's the pre-op images. What do you think? Let's have a show of hands. How many would call this left frontal lobe or left frontal mass? No, it's not. It's right in the center, the lenticular nucleus. Okay, maybe the biopsy. Yeah, I should. Let's back up. I want to redo on that. Okay, hypothesis. They actually, part of the tumor in another cut, you know, maybe on the coronals a little more anterior, maybe the tumor was involving the left frontal lobe and they decided it would be safer to take a bit of left frontal lobe. Is that what happened? No, we always check the post-op. You can see the post-op CT on the left-hand panel. And as you can see here, the air bubbles right in the center where the lesion was. And then here's the gradient echo, the T2. T2, and you can see that's the biopsy site. We confirmed it, we proved it, we did our due diligence. This is one of the things that makes, listen, this is one of the things that makes practicing oncologic neuropathology so satisfying and intriguing in this era when we have access to the entire electronic medical record and we can do things like this right at our desk. Why would you not? Why would you want to practice such a constricted form of practice that all you do is look at H&Es and immunos and molecular signature? Why would you do that? Okay, with respect to this case, the sheet said left frontal mass. It wasn't. Hence, trust no one, believe nothing. I love that quote, and they always go in that order, and this comes from the great Feroz Tamboli, Professor of Pathology, MD Anderson Cancer Center. This is a statement that I have heard him make for a decade when he's giving the introduction to his subspecialty, GU, to our entering oncologic fellows, surgical pathology fellows. Trust no one, believe nothing, confirm it, use your brain. All right, we still have a problem to deal with, don't we? How should we handle the referring institution, quote, left frontal mass designation as a tissue source? Do you know what the referring institution pathologist did? Well, I showed you. They just put it in the report. What did they, their pathology report, which came to us, it said left frontal mass, glioblastoma. That's telling the neuro-oncologist, left frontal mass, glioblastoma. It's telling the radiation oncologist, left frontal lobe, glioblastoma. Well, what do? Do we just ignore it? No, you can't ignore it. How do you handle it? This is how I handled it. Now, this is not a one-off phenomenon, you know, a hapax legomenon. No, it's not a hapax. This happens a lot. All right, here's how I handled it. 6 outside slides. Brain designated, quote, left frontal mass, end quote, parenthesis, left lenticular nucleus by preoperative and post-biopsy imaging, stereotactic biopsy, and there's the diagnosis. That way, everything is there. You can still acknowledge what it was called, but you put the truth. You put the truth in your report. Look, I want my reports to be as truthful, as accurate, and as precise as I can make them. All right. A lot of pathologists don't seem to care about that. All they want to do is make an instant pattern recognition, make a diagnosis, and go home, I guess. All right, here's the comment. Underlined in red, pencil bundles of Wilson are identified in some tissue fragments, consistent with biopsy of the left basal ganglia, the lenticular nucleus to be specific, on post-operative CT and MR imaging studies. And look at the last paragraph. We always address imaging. Diagnosis of glioblastoma congruent with preoperative MRI, should have been MR imaging studies performed for referring institution available in MDC Epic, which show a rim-enhancing expansile lesion centered in the left lenticular nucleus. Done. Okay, let's move on. Genomic alteration differential diagnosis, instant pattern recognition. That's kind of a mouthful, isn't it? That's why I just said IPR. Okay, this is going to be genomic alteration. Now, it's a differential diagnosis, so it will be a differential. You don't have to give me the exact. I'll accept. Why don't you give me the top two entities in your differential? Okay, you ready? Now, I'm going to give you a big piece of information. I'm going to give you actually two spheres of the H-sphere Venn diagram model for precise diagnosis. The age, 15 months of age, and female. All right. Either or both of those could be very important, so you know that. All right, are you ready? All right, I'd like to hear some answers. Just the top two. Here it is, molecular signature. It's an IPR. What are the top two entities in your differential diagnosis for the brain tumor that this child has? Okay, and yes, Dr. Gilbert, medulloblastoma went altered. So went altered medulloblastoma, which would be great news. All right, Dr. Cathcart, right behind her, adamantinomatous craniopharyngioma. All right, I love it. You know what? Let's stop, take the gate. All right, and it was a missense mutation of CTNNB1. What is that? That is catenin beta 1. That's all it means. All right, the differential diagnosis, medulloblastoma, went activated. Remember this table from Cower and colleagues in Brain Pathology 2015? Upper left, I've identified it there. The Wnt is defined molecularly by aberrant nuclear translocation of beta-catenin. You can see the nuclei are lighting up. Cytoplasm is too, but that doesn't count. The beta-catenin is not nuclear localization in sonic hedgehog-driven medulloblastoma or in the non-Wnt, non-sonic hedgehog-driven. So it's absolutely definitive. All right, that is diagnosis number one. Diagnosis number two, craniopharyngioma, adamantinomatous subtype. Quick question, what is the molecular driver of the papillary subtype? Yes, good job. Lopez, Dr. Lopez, yes, BREF V600E, Dr. Alfatal, BREF V600E, excellent. All right, craniopharyngioma, adamantinomatous. Listen, not every cell is going to show beautiful nuclear positivity in adamantinomatous craniopharyngioma for beta-catenin. Mostly it will be in the whorls, as you see here with the arrows, and at the advancing edge, at the outer edges, in those palisades. But if you have a big enough sample and look closely, you will see them. The membranous, this beautiful membranous staining, that is a quote, a negative. You wouldn't put it that way, but that's a negative stain. Only the aberrant nuclear translocation is consonant with the disease. All right, this is the answer. Which does the child have? The answer is in the imaging. This is clearly a cellular, supracellular cystic mass. Is absolutely right, Dr. Cathcart, Dr. Gilbert. Yeah, Giselle, correct, right on the money, Dr. Alfatal. Yes, this is a cystic adamantinomatous craniopharyngioma. Now, hang on a second. We know it's not medulla, it's not the cerebellum, yada, yada, yada. Okay, we know that we have the molecular signature. But look, here was the point. Think with me just a second. You know, another way I could have done this is just show you that sagittal, show that sagittal image with the molecular signature, just those two panels. Then I would not have asked for a differential. I would just have said, what's your diagnosis? And 99.9% chance it's going to be an adamantinomatous craniopharyngioma. Now, question, I thought that craniopharyngiomas, really of both subtypes, were heterogeneous, solid, and cystic. You know, big, irregular, kind of lobulated, some cystic parts, some solid parts, calcification. This is a cyst. It's one cyst. Right, a little bit lumpy, a little bit along some of the edges. It's monocystic craniopharyngioma. It's trying to mimic a Rathke cyst. Does that happen? Of course it happens. Everything happens. It's like saying, are there morphologic variants of tumors? Well, there are 22 morphologic variants of glioblastoma on H&E stains. There are 13 morphologic variants of meningioma. Yes, there are morphologic, and I will call them morphologic, there are morphologic variants of craniopharyngioma imaging. Would you like to see a few? Well, fortunately, it's my conference. You don't have a choice. Here's just on the CT scan. Look at this ring calcification. This case was also densely calcified. All right, just wanted to show those, solid ring. All right, here's the diagnosis. Endoscopic intranasal transtubercular resection, craniopharyngioma, adamantinomatous very heavily calcified, and it was a recurrent tumor. Patient had a history craniopharyngioma diagnosed at 15 months of age. Those were the images that I showed you, the pre-op images. and they were reviewed, the images. That's how I'm able to show them to you. H&E shows adamantous craniopharyngioma with calcification. One fragment of adenohypophyseal tissue is present. I think it is important to document everything that you see in the slide that could be of significance. That's why that's there. And look at the last part. This is addressing the imaging, as we always do in the last paragraph of a complete report, whenever we can, whenever we have the data. Look at the last part of the sentence. I'm simply saying that the dense calcification we saw is confirmed intraoperatively by direct visualization by the patient's neurosurgeon, Dr. Sean Raza at MD Anderson. See op note in the chart. Did I actually go to the, yes, I actually went to Epic, to the chart, and looked it up. I wanted to know exactly what the neurosurgeon saw, and he confirmed that. In this particular case, it wasn't critical to the diagnosis, but I wanted to know. In other instances, it has been very important to see exactly under direct visualization what the surgeon saw, the anatomic planes that were involved, the exact compartment that was involved. You can't always tell from the pre-op imaging, as good as our pre-op imaging is. Sometimes there is no substitute from turning a flap and having a look. And that's available to us as neuroradiologists or radiologists and pathologists. That is available to us in the electronic medical record. Don't forget about the surgeon's op note. Doesn't matter what specialty you're in. All right, here's the spectrum I promised you. These are 10 different craniopharyngioma patients. Only one of them, the bottom far right, was a papillary. All the rest were adamantinomatous. Start with the upper left. If you see, it's a cystic lesion, mostly in the sella, just coming out. All right, looks like a Rathke cyst. It was mimicking Rathke cyst. The other entity in the diagnosis would be cystic pituitary adenoma. Can cystic pituitary adenomas ever look like that? Yes. They can be primarily cysts? Yes. Same thing. This was tissue-proven adamantinomatous craniopharyngioma. Now, if you look across the series, I just pull patients showing larger and larger and larger. This was the monstrous craniopharyngioma that I've showed previously in this conference before, the one on the far right. That is one giant. There actually were a few other smaller cysts in different compartments. That's a monster cyst. Now look at the bottom panel. In contrast, this is just a series of patients showing increasing sizes. And these are all, listen, these are all at clinical presentation. Now the case I presented today was recurrent at presentation. These are primarily solid with internal multiple cysts. And this is more typically, I think, what we think of, most of us, when we think of craniopharyngioma. And if you were to see the axial sections and the coronal sections, this would be going off in all different directions. Okay, most of the time in pathology conferences, you get one picture. And then just one image of each of the defining histologic features. I think it's important to see a spectrum so that you don't have a situation where you see one case, let's say of an entity that you had not encountered before, and you tend to hold that as the idiotype, like they all must look like this or very close to it, and that's always a mistake. So whenever I can, I will show you the spectrum, all right, a spectrum of morphology, both imaging and pathology. Okay, everyone ready to move on to patient one? I think that's a good warm-up. Took us a little over half an hour to warm up. I think you're ready for the first patient. All right, this is a 36-year-old female. Again, I have given you two differential diagnosis spheres. The patient is 36 years old, that's young adult, and female. All right, keep in mind that information. Now I give you imaging. Now the imaging actually gives you two additional spheres. Number one, precise anatomic location, and number two, the imaging features. Imaging features would be sharply circumscribed versus diffusely infiltrating, enhancing, not enhancing, T2 hyperintense, T2 hypointense, same thing for T1. All right, you can see this tumor is localized within the left temporal lobe. It is sharply circumscribed. It is cystic. You can see that on the T2 and the T2 flare. And if you look at the second image here, the T1 post-contrast on the left, it has an enhancing mural nodule. Now it's a little messy. It's not a beautiful sphere, like a nodule is a sphere, but there's an enhancing component, right? And you can see that in negative relief on the T2 and the T2 flare. Question: in this patient of this age, what is your differential diagnosis? All right. Dr. Gilbert says pilocytic astrocytoma. Absolutely. I got pilocytic astrocytoma from Dr. Harb. Good, Dr. Awfultall. PXA. All right. I'm looking for one more PXA. Oh, DNET from Giselle. I like that. That's creative. Ganglioglioma from Dr. Gilbert. Yes, and Quan. Thank you. Good. And Quan also. All right. Look, here was the point. Good. We could stop there. Now remember, the list could go on and on and on. This is bread and butter, case one. This was the point. Young adult, temporal lobe, sharply circumscribed tumor, cystic, mural nodule. Oh, and I forgot to point out, key, how much surrounding edema do you see on the T2? And look at the T2 flare. You barely see a little at the top. It's not doing much in terms of that. All of those features are screaming lower grade primary brain tumor. They're screaming at the top of your differential. There are always exceptions. And of course, you would want to know the clinical history. Was this 2 weeks of headache, nausea, vomiting? I might rethink it. Is this 1 year of increasing maybe absence seizures, which are not recognized, something like that? Okay, these are the big three. Pilocytic astrocytoma, pleomorphic xanthoastrocytoma, and ganglioma. Absolutely, there are other entities in your differential, in the differential. Sorry, I don't like to use the personal pronouns for diseases and stains and tumors, but I lapse into it. Yes, even me, even good Homer stumbles. All right, so pilocytic, PXA, ganglioglioma. Here's the histology. What's your diagnosis? What is your diagnosis? I'm just going to show you the one H&E panel. You should not be thinking pilocytic. It's not spindle, okay? Bottom line is you should be thinking it's either PXA or ganglioglioma because you see big cells. There's one up top here. These big cells, that one has a prominent nucleolus, and I don't really see Nissl substance, the rough endoplasmic reticulum. Okay, here's what you need to do for these big cells. You must run synaptophysin and or NuN, neuronal nuclear marker, to see if these are atypical ganglion cells or if there are atypical ganglion cells to rule out ganglioglioma. Now listen, quick word about ganglioglioma, the morphology. Gangliogliomas by definition must have a ganglion cell component and a glioma component. The glioma component very frequently, at least 2/3 of cases, will be pilocytic in morphology, spindle. All right, in morphology. The ganglion cell component varies greatly in terms of how much of the tumor it composes. In many cases, the ganglion cells are scattered. They are rare. And on frozen section, you might think, oh, beautiful PXA. And then sure enough, when you get the perms, oh, some of these guys look like they have Nissl substance. You run NuN, synaptophysin, they light up. Oh, that's going to be the ganglion cells, binucleate ganglion cells. Then you got to go to ganglioglioma. Now, I feel like I have to add really quickly that, you know, PXA, the cells can be positive for synaptophysin, but they're not convincing as ganglion cells, and that's the difference. Okay, everybody got that? And of course, #1 molecular signature for this tumor, BRAF V600E. Absolutely. Okay, that was a nice differential diagnosis exercise. Everyone did a great job with that. In this particular case, it turned out to be PXA. Okay, let's move on. Patient #2. All right, I want to stay with young adults. So we're having even younger patients, 30-year-old male, and this is a similar lesion. What you're seeing here, upper left panel is axial T1 with gadolinium, T2 to the right of that, T2 flare to the right of that. And again, we're going to make the observation, there's some vasogenic edema, but it's not particularly impressive. And then I just showed a coronal T1 with contrast, which shows it's in a slightly different plane. You can see it up here. It's a little nodular, all right? It's got some stuff going on in the wall, okay? So now you have age of the patient, gender of the patient, anatomical location, imaging characteristics, all right? Because this study was done, and I thought it was really nice, even in a cystic tumor, I'm gonna give everyone a chance to identify sequences. Does everyone, I'm not really the pathologist. I know our neuroradiologists know these sequences. Pathologists, you come up with this, okay? I'm wanting sequences here, okay? See, just a sequence. What's the top row? What's the bottom row? Okay, I'm not going to beat it to death. The top row is DWI, diffusion weighted imaging, and the bottom is the ADC map. Correct, Dr. Cathcart. Now listen, the top is diffusion weighted. right? And so what you see is no restricted diffusion in the cyst. By definition, a cyst is water, correct? And there's no restriction of diffusion in water. That's what they do. That's the point. Water moves around. To restrict the movement of water molecules, you have to hold them. You have to compartmentalize them. You have to restrict them, like would happen in an abscess, right? Or a densely cellular tumor, or an infarct, acute, subacute infarct, right? Okay. Now, the point that there is, however, so there's no restricted diffusion. See how on the DWI, see how dark the cyst is? So there's no restricted diffusion there. There is restricted diffusion in the wall, right? In that irregular area. Can everyone identify that? All right, let's see. See right here and right here and here. And sure enough, like let's just take this one. When you look at go to the bottom, you look at the ADC map, the apparent diffusion coefficient map, and sure enough, it's dark. It's hypo intense. Okay. Let's go to, let's see, yeah, there's the sequences labeled. And just to look at these two, I thought this was a nice example. Again, just so you can see it more easily. See how intense, how hyper intense this is on diffusion weighted. That's restricted diffusion. And then look how dark. See how hypo intense, how dark it is on the ADC map. So we're just excluding T2 shine through. That is absolutely restricted diffusion. All right, in the wall, in that component of the wall. And here's the point, just to jump ahead. Remember the categories of restricted diffusion will be things like pyogenic abscess, epidermoid cyst, densely cellular tumors like diffuse large B-cell lymphoma. All right, so this is probably going to be densely cellular. Okay, all right, let's look at the tissue. Intraoperative consultation, frozen section slide. What kind of procedure? What procedure was done here? What do we have? You see that? Look, use all your information. Can everyone see the scale bar down here? That says 3 millimeters, right? When we use digitize, this is one of the beautiful things about taking histology from whole slide imaging is we can always have a scale bar built in, which is more accurate than just putting a magnification, 20x, 40x, et cetera. Okay, so this is what type of procedure was performed? Stereotactic biopsy. What's your opinion? Can I have some opinions about that? Does that give you pause? Or are you just like a robot? Oh, I've seen the imaging, and I think I've got the differential diagnosis, and I just want to look at the tissue. I don't even want to think about it. And the minute you open this folder, let's say it's an outside, it's going to be an outside case. You open the folder of slides, and you see all these. Every slide has just a little bit, and you're thinking, no, I looked at it. Did we miss the lesion? Yeah, great comment. That's a good one. But here's the thing. But miss the lesion. Why stereotactic? Did anyone think that we just looked at a case of pilocytic PXA ganglioma and that this imaging in a young adult looks really similar and very little T2 flare surrounding vasogenic edema? Wouldn't you include in this young adult PXA ganglioma and pilocytic, wouldn't it? And if it would, do we perform stereotactic biopsies on a pilocytic or ganglioma or PXA in non-eloquent cortex? No. Yes, Dr. Gilbert, Dr. Harb, no. Now look, that should give you pause. It's a red flag. It's an incongruity. This is a good thing. It's not a bad thing. This is a mystery. This is why we're pathologists. Our job is to figure it out. You should be thinking, wait a minute, something is not quite right. Something is off here. We need to figure it out. You like that? Okay, well, let's move on. Let's go to higher power. Okay, what type of histologic preparation are we looking at? What's the preparation? It's a stereotactic biopsy. What are we looking at? Is this a smear? Yes, frozen section. Good job. The answer is frozen section, right? It's clearly, it's a stereotactic biopsy. It's H&E. The key was to see, look right here in the center. Can you see the ice crystal formation? This is not, the reason why it looks so much like an FFPE section is because it is an FFPE section. It's the frozen section tissue, which has been processed into formalin-fixed paraffin-embedded block. And it's these ice crystals. See the linear arrays in different directions? Now, why is that important? It's important for two reasons. Number one, the nuclei that you're looking at are likely to be distorted, right? The cell shape is likely to be distorted as well. And number two, some antibodies don't work. Yes, Dr. Gilbert, exactly. For example, S100 protein, many of those antibodies are notorious for not working on frozen section, all right? The antigen, the epitope is simply masked, right? You won't see it, and you need to know that. Let's say you're thinking melanoma or any other tumor for which S100 is critical and you're only gonna run an S100, it may not work and it's a false negative. That's important knowledge. That's the stuff that pathologists have to know. Okay, so that's good. All right, and anyway, bottom line, yeah, essentially normal brain will hand them gliosis. Will hand them gliosis just barely. All right, just barely. So what is going on? Whoa, it's interesting, isn't it? Yeah, there's a higher power. You can see there's gray matter here. Neurons, neuropil, et cetera, nothing go on. Ki-67, maybe one nucleus. No other tumor markers, P50, nothing labeling, okay? All right, here is specimen B. That was specimen A. Look at B. Oh, this is quite a different story. Have a look at this. What you're seeing, look at the far right. See the far right corner? That is necrosis. And then look at the dense cellularity bordering it. And as we go further out, go all the way out to the margin there. That is the cortical ribbon. It looks relatively normal. This is what we received as specimen A for frozen that was read as normal negative. All right, here, look, here is the interface between the cortical ribbon and, between the cortical ribbon and the underlying tumor. Now, does that make sense? Yeah, it kind of makes sense. Remember, on the pre-op imaging, the surrounding vasogenic edema was very modest, and that's making sense. That's fitting. All right, so let's go up to higher power. All right, and yeah, just to show you again, this restricted diffusion, which we postulated to be densely cellular tumor, it is densely cellular tumor, as you can see right here. It's glioblastoma, right? But there's a relatively sharp margin between the tumor. In other words, there's a relatively low, oops, didn't mean to do that. There's a relatively narrow zone of infiltration, and you put that together with the pre-op imaging, which was mimicking a circumscribed tumor, JPA-PXA ganglioglioma. This is cystic glioblastoma. So if you haven't seen it before from the beginning, you know, not like reading about it in a book or a paper where the title says cystic glioblastoma. Yeah, how smart are you to realize a paper, you know, the images are cystic glioblastoma in a paper that says cystic glioblastoma. If you have not encountered this before, all right, and again, I'm going to back up. We're going to back up, back. This is so important, all right, right here to the original imaging. This is cystic glioblastoma. It looks very similar, including the very minimal to almost no vasogenic edema to circumscribed tumor, cyst, neural nodule, et cetera. Okay, that's a point I wanted to make. All right, let's have a quick look at cystic glioblastoma. This is a paper the MD Anderson group published back in 2004. Wow, 16 years ago. This is 22 cases. These were 3 patients. The upper panel is the T1 with contrast pre-op. And look, doesn't that look very similar to a patient? See, in the wall, you got just a little bit of nodularity. And look at this. We don't show the T2 and T2 flare, but you can see just a little bit of edema. It's certainly not massive. And then post-op gross total resection. Remember, gross total resection is defined for glioblastomas as removing all of the enhancing component, not all of the tumor, all of the enhancing component. All right, and here's the statistics. Basically, the time to recurrence was much better, much longer in the cystic tumors. And that's probably because of the narrow margin. Unfortunately, overall survival was not better. At least it did not reach statistical significance in these 22 patients, all right? But certainly progression-free survival was better. And again, here's the beautiful histology panel. I can say that because I put it together. And here, again, here's the lumen. That's the lumen of the cyst. All right, have the pseudoepithelial lining here. Here's the glioblastoma. Here is the interface, all right, between the tumor proper and the surrounding brain. Only ½ centimeter. And that was pretty much all the way around except for that little bit of the lumpy, and most of the lumpy stuff was going into the cyst, not into the brain. And here, look at the zone of infiltration. There are no tumor cells here. If this had been an IDH mutant, you would have found virtually no cells out here labeling. Look how narrow it is. That is cystic glioblastoma. And hang on a second, that is why the first stereotactic biopsy missed the lesion. because you're either in the cyst and you get fluid, or you're in the brain around it and you get essential normal brain moly hypercellular non-diagnostic. You have to hit that 0.5 centimeter rim. It could be a difficult hit for a stereotactic. And this is, again, this is a current case. And it beautifully illustrates the difficulty, all right, with this. So let's say you're a surgical pathologist, you're a pathologist, and you look at the OR schedule for the next morning, and you see one of these cases. Which is probably because of the T2 flare, looking at all the cuts, yada, 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 okay, that the suspicion is that it's going to be glioblastoma, 65-year, whatever, okay, and you're looking at that imaging as a pathologist who's going to be doing a frozen, all right, what do you want to see on that surgery list? What you want to see is craniotomy. What you don't really want to see is stereotactic biopsy, because you know that the surgeon, even good skilled surgeon with intraop navigation, I know how good it is going to have to hit that half centimeter margin. All right, right on. Yes, and they advance it. Okay, everybody got that? Now, this is what's called, with experience, you can anticipate the problem cases at frozen. So we talk about frozen. I give a little lecture on how to handle brain frozen sections and problems and issues and stuff. One of the keys is anticipating beforehand the potential problems. And in this particular case, quick question, was that frozen, the frozen section A, was that hard for the pathologist? It wouldn't be hard for me. Wouldn't be hard at all. The answer is it's normal brain. The answer is, or it's gliosis. The answer is, I do not have anything to explain the contrast enhancement or the restricted diffusion on the pre-op imaging. This is definitely a non-represent biopsy. And I would say that with confidence, knowing, as long as I knew, the pre-op imaging in this case. Okay, again, let's look at spectrum. Spectrum of imaging morphology of cystic glioblastoma, 10 cases. These are all different patients. You like that? I actually have more than 10. Let's look at a few more. I think this is a very nice, and again, these are all tissue proven cystic glioblastoma. I mean, look how clean and narrow and regular that rim is. And here on the T2, very little edema, same thing mimicked on the T2 flare, very little vasogenic edema. This one's even better. I mean, check this out. Look at that. That is trying to be, albeit a giant abscess. That's trying to be a pyogenic abscess in terms of the regularity of the ring and constant diameter. Of course, it does not restrict diffusion, et cetera, et cetera. Look at the T2. Very little edema. There is mass effect, very little edema. Here's another example, a little irregular, same thing. Another example. Now this one is getting a little bit messy. Getting a little bit messy here. It's going outside the ring. We can also see that reflected in the T2, all right, and messier, thicker. I mean, that's an obvious, all right, as you can see, what I'm doing here is we're transitioning to more complicated cases. Oh, this case, I love this case. What's going on with the arrow? Anybody want to, let me take a break here for just a second. By just a second, I mean 2 seconds. Yeah, fluid level. Esther, I have a very good fluid level. Andrew Gilbert, fluid. But what's a name I like? There's a name I like even better than that, because it's so colorful. I like this, hematocrit level. Isn't that cool? Because that's really what it is. It's a blood product separating at hematocrit level. I think that is super cool. I learned that from Dr. Sanjay Singh, preeminent Texas Medical Center neuroradiologist. Love it. Okay, even messier. Look at the component. Look at the component on this one. And here's another one. Clearly a lot going on besides the cyst. Okay, and at this point, we're cyst with a very large mural mass. And look at this one. Yeah, actually, that's kind of cute, because that's looking like a circumscribed cyst with a mural nodule. Again, proven glioblastoma. And one of my favorites, this is an axial cut where we're actually capturing sort of the temporal lobe and the frontal lobes. It's bending around the sphenoid, but it's looking here, it's having a bicystic binodule appearance. And I just want to last examples just to show you the MRS, the proton MR spectroscopy of the mass. See the voxel. So on the right, you can see normal brain. It's single voxel. Up is good, Hunter's angle. Down is bad. Here, the voxel on the left is set right in that mass. A highly elevated choline to creatine ratio, ginormously increased. Suppressed NAA, which is a neuronal signal, and then lactate peak, inverted lactate peak. All right. I thought that was a nice example. Okay, just a caveat before we move on. We're about to move on. Caveat, be careful. Looks like the same thing, doesn't it? And you may be thinking, is this going to be JPA-PXA ganglioglioma, or is it cystic glioblastoma? Well, it's metastatic melanoma, cystic. Yeah, everything occurs. Everything occurs. Metastatic cystic melanoma in a young adult, unfortunately, yes, we see too much of it at MD Anderson. Okay, we're going to keep moving here. I know we only have 5 minutes, but I'm not stopping because I'm going to present all the material that I think you need to know. Intelligent pronunciation. All right, let's look at this. COVID-19, a lot of talk about where did it come from. I think first it was going to be pigs, pig farm, and then it's bats. And this is done by sequence homologies. And then some things, well, maybe it's pigs or bats, but it was definitely bioengineered in a lab. And then probably not deliberately released, but just leaked out, just sloppiness, I don't know. But anyhow, this raises the possibility of this type of disease. Is this zoonotic disease? Is it zoonotic? Is that how you say it? Zoonotic? No, Andrew Gilbert says, no, it absolutely is not zoonotic. All right. How do you pronounce this, the related word? Is it zoology? Have you ever heard zoology? Yes. And you'll see it in the movies. You'll see it in the movies all the time. It's pathetic. All right. There is no zoo in zoology. It is a beastly mispronunciation. Many of you may recognize this as the book by the same author who wrote, Is There a Cow in Moscow? Yes, not Moscow. No, Moscow. Moscow, no. All right, here are 3 terms. All right, is it zoonosis, zoonoses, zoonotic? No. Zoonosis, zoonoses, zoonotic. All right, let's go to Wikipedia. All right, see underlined in red? There's the pronunciation guide to the right. You see all those strange characters? All right, that is IPA. Let's go to Wikipedia. What is IPA? International Phonetic Alphabet. There is help. Here is the table. All right, here is that unusual O with an inverted omega sign. That's critical. We need to know, how do you pronounce it? So here is the pronunciation key for this word, Z-O upside down omega sign. How do you pronounce it? Here's from the table, goat, code, full, bone, go, go. That is zo. Zo. Now look at the accent, where the accent is in the preferred pronunciation. It's on the second syllable, which is on. Zoonosis. Zoonosis. Look at this. Zoonosis. Yeah. Or zoonosis. See the accent mark before third syllable? Zoonosis. 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 Isn't that super cool? All right. And there's just we already covered that. All right. And of course, there's all these, you can click it. And in different countries might actually use zoonosis, but it's so ignorant. I mean, come on. All right. Sorry. Let's go back. I could have made this easier by just going to Webster, because Webster doesn't use the IPA. Look at this. Z-O. You know that long bar over the O? That's zo. Zoonosis. 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 Zoonoses. Did you learn something today? Yeah, I hope you did. Okay, that is intelligent. Now here's the key with intelligent pronunciation. And I'm gonna stop because we're almost there. I do have one more case. We can save it till next week. Here's the thing. I just wanted to show you what the experts say. You do not have to pronounce it that way. You can say zoonosis. Absolutely. You can say zoology. But the key is to know what the history is, what the preferred pronunciation is, so that when you do use the term deliberately, you will know that you may be held accountable by someone in your audience who will use it as a lever to force themselves into your lecture and start lecturing, right? And I've talked about this once before. I'll conclude with a statement. You know you're in trouble when you conclude a lecture and you ask if there are any questions, and a hand goes up, guy stands up and he says, do you think that the yada, 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 because? The minute they say because, you're in for a lecture. Okay, that's just a little wisdom. I'll tell you what, we're going to stop here because we're right at the hour. I will save the last case I had for this until next time. I did have the last slide, which says follow me on Twitter, hashtag Greg Fuller MD PhD. You can find unknowns there. And I just launched, in conjunction with my beautiful wife Tina, a YouTube page, and that's where you're going to have to go to get the answer to the last challenge. Okay, I think that's enough. We'll call it stop there. Again, thanks to everyone for attending, and I will definitely see you next week.